Hello, my name is Annie Ferreri. In this presentation, I will discuss my IRB proposal study. The focus of this study is on iron deficiency anemia in adolescent females. The title and proposed research topic is on the effects of a dietary intervention in adolescent females with iron deficiency anemia in the United States. The micronutrient of concern is, of course, iron. So why do we want to look at iron deficiency anemia in adolescent females? Anemia caused by iron deficiency is a very common disorder impacting up to 2 billion people worldwide, or 1/3 of the population. Of that prevalence, female adolescents make up 30%. This population has distinct risk factors, which makes them a high concern for undiagnosed or untreated iron deficiency anemia. In adolescent females, the onset of menstruation causes potentially heavy blood loss on a regular basis. This population also presents with certain dietary and lifestyle patterns, such as a reduced meal size, skipping meals, or unhealthy meal choices, which could be a result of societal influences on weight or lifestyle patterns. Iron deficiency anemia can be difficult to diagnose since common symptoms include a general set of criteria such as weakness, fatigue, or difficulty concentrating. If left untreated, iron deficiency anemia could result in developmental delays, a decrease in cognitive functioning, and complications later in life, especially during pregnancy. So why do we want to study a dietary intervention as a treatment method? The most common treatment for iron deficiency anemia is iron supplementation. It can be challenging for adolescent females to maintain a normal regimen of oral iron supplementation due to uncomfortable side effects such as nausea and constipation. The proposed study will look at a treatment through nutritional focus to assess if a dietary intervention will be an effective treatment method for iron deficiency anemia in adolescent females. Specifically, we will determine if a monitored meal intake, which meets the recommended dietary allowances for iron, will be an effective treatment method for those who do not currently consume adequate iron according to the RDAs. The research question proposed for this study is the following. Does following a 6-week dietary program, which provides the recommended dietary allowances for RDAs for iron intake based on age, change serum ferritin and hemoglobin values in female adolescents ages 13 to 17 with iron deficiency anemia whose current diets do not meet the RDAs? The alternative hypothesis for this study is that there is an improved change in serum ferritin and hemoglobin values in adolescent females with iron deficiency anemia whose current diets do not meet the recommended dietary allowances that follow a 6-week dietary program which meets the RDAs for iron intake based on age. Our goal is to determine if a change in dietary iron intake has an impact on female adolescents ages 13 to 17 who are diagnosed with iron deficiency anemia, specifically in adolescent females whose current diets are falling below the RDAs for iron intake. The goal will be reached by comparing serum ferritin and hemoglobin values in female adolescents with iron deficiency anemia before and after the subjects take part in a 6-week dietary program. In order to assess current diets, subjects will first submit a 1-week food journal, and those subjects who are falling short of the RDAs for iron will be placed on a monitored dietary program which provides daily meals that meet the RDAs for iron intake based on age and the dietary preference of each subject. The current RDAs for iron intake in adolescent females range from 8 to 18 milligrams per day. Available data suggests that adolescent females may only be consuming up to 10 to 11 milligrams per day of iron. During adolescence, lean body mass increases and total blood volume expands. For females, this time period is usually accompanied by the onset of menstruation. The prevalence of iron deficiency in the United States is highest among female adolescents from ages 16 to 19, at 9 to 16%. Iron deficiency anemia has been linked to developmental delays or impaired or decreased cognitive functioning in adolescent females, as we mentioned. A study in Palestine found that a significant concern in dietary habits among adolescent females, such as skipping breakfast, eating junk food, and limited intake of fruits and vegetables. In addition to unhealthy dietary patterns and meal skipping, dietary restraint has also been associated with iron deficiency. A study analyzing female adolescents ages 14 to 15 years old in London found an overall concern with a low dietary iron intake. Another study in Poland found that while the prevalence of iron deficiency anemia was low, nearly half of the adolescent females had inadequate iron stores, which presents a concern for continued development. Emerging literature has discovered positive impact on dietary changes and anemia in adolescent females, some of which have included nutrition education components versus those with no intervention or only iron supplementation as treatment. A final study in Palestine analyzing female adolescents from ages 15 to 19 with iron deficiency anemia found that a combination of oral iron supplementation and nutrition education had a better long-term outcome on iron and hemoglobin levels than just iron supplementation alone. So simply looking at the prevalence rate of iron deficiency anemia in adolescent females justifies the significance of this study. Recently, there has been increased interest in alternative and nutritionally focused treatment methods to iron deficiency anemia, since early dietary intervention can have a lifelong impact on health. There is limited research on this topic out of the US, as most studies have taken place abroad in regions such as Europe, Asia, and Africa. Research in the US would promote awareness and, ideally, with additional relevant research in the field, impact routine screening guidelines for iron deficiency anemia, and potentially focus on nutrition education with an analysis of RDAs in this population. The proposed study will initiate subject recruitment in the offices of primary care physicians located in Houston, Texas. This city has been identified for this study because it is the fourth largest city in the US. Recruitment will use handouts and flyers in the primary care physicians' offices. The intervention will take place during the summer months of mid-June to early August as to not impact school meals. The inclusion criteria is as follows: female adolescents between the ages of 13 to 17 with a current diagnosis of IDA, or iron deficiency anemia. The exclusion criteria are those currently taking any form of iron supplementation, genetic disposition to iron toxicity, such as hemochromatosis, pregnancy, tobacco and alcohol use, medications which can interfere with iron absorption, and conditions which can impact blood work. Further, the study will require 65 subjects. An a priori for sample size was calculated in G-Power using a two-tailed t-test for one sample case, with a medium effect size of 0.5, significance level of 0.05, and a power of 0.95. This resulted in a sample size of 54. And for this study, we are estimating attrition to be at 20%. Therefore, 65 participants are required for this study. Study procedures include a 1-week food journal, initial baseline lab work, a 6-week dietary intervention program, and a retest of lab work upon completion of the intervention. Initial lab work will confirm anemia in subjects with a serum ferritin concentration of less than 10 micrograms per liter and a hemoglobin concentration of less than 12 grams per deciliter. Initial lab work results will be recorded by the research team electronically within subject records on a secure data recording software program. Participants will then complete a 1-week food journal to identify adequate RDAs. Those who are not meeting RDAs will proceed, and those who are meeting RDAs will be dismissed from the study, as a more severe iron deficiency anemia is not the focus for this study. Round 2 of recruitment will take place if we do not end up proceeding with all 65 initial subjects. The intervention program will be in partnership with a contracted meal delivery program, which provides meals to patients in need of a clinically focused diet. The meals are developed by registered dietitians and delivered straight to the patient's home. Data recording for the intervention will be done through a mobile application created by the meal delivery company to track all delivered meals and record subject consumption. The anticipated timeline for this research study is 6 months. And of course, subjects and their parents or legal guardians will be required to sign an informed consent form before participating in the study because of our use of research in minors. The essential data analysis for this study is the comparison of blood work before and after the intervention. This will be quantitative data in the form of recorded lab values. All subjects in the study will take part in the intervention program, so there is no need for a control group or randomized assignment. Therefore, this will be a quasi-experimental study by design. The analysis for the study will consist of a one-group pre-test, post-test design to analyze changes in serum ferritin and hemoglobin values of the 65 subjects. This method is ideal in a single group of participants which all have the same conditions of the intervention program. The difference in serum ferritin and hemoglobin values will be calculated between the initial and the retested lab work. The research team will utilize SPSS version 22 for data analysis as a software program. A one-sample t-test will be used to test for differences in the sample and hypothesized mean from prior studies for changes in blood work results. The data will be reported anonymously with an overall analysis for changes in serum ferritin and hemoglobin values for the group. If the results of the study lean in our favor, the knowledge gained from the proposed research could provide an advancement in the field of iron deficiency anemia in adolescent females, which is not only valuable for the medical community, but also beneficial to the field of nutrition science. In addition to the generally accepted treatment method in the form of iron supplementation, there could also be a nutritional component to assess for dietary intake. Risks that have been identified in this study include physical, psychological, or social harm. And of course, there's an additional risk since we are using minors as subjects. The benefits include an alternative treatment to iron deficiency anemia with potentially less side effects, complementary meal plan for the duration of the intervention program, and a nutrition education component which can continue upon completion of the program through the use of the app. The limitations include the contracted company for meals, which takes any control over the meals provided away from the research team, and self-reporting and recall bias in the use of food journals and meal consumption for recording. The basis for this study is to utilize nutrition as a frontline treatment for disease. Adolescent females hold the ability to make sufficient diet and lifestyle changes early on in life to treat a condition like iron deficiency anemia, which can have a lifelong impact on health. This concludes the presentation. Thank you for your time.